Let's talk about Parkinson's disease and rehabilitation. We know that Parkinson's has a lot of common problems and some strange problems that all need addressing that the pills can't do. The thing is, most people that are making the diagnosis and prescribing the pills know this, but they don't know what to do. So they keep writing a particular thing on their prescriptions, therapy, 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 hoping that it's going to solve the problem. The thing is that people prescribing this therapy often don't know what it is or what's supposed to happen. So when things get missed, they assume it's just a bad disease, but it could be much more. Today's talk is to open up that black box and make it obvious to everyone what actually happens. If you want to treat a disease, you just need some pills. You just need to figure out the body functions and structures, put a health condition label on it, and then from there, get the person pills and send them. But if you want to treat people, things change. So you have a person who now has a problem, and they come to a doctor saying something's not working. The doctor looks at body function, body structure, comes to a health condition diagnosis, and okay, the most common thing that happens is get your pills, go home. Now, with this kind of a model, you can treat a couple hundred people in a day. You just get a history and examine pills, right? But that's not addressing a lot of other things that concern the actual person who's come. And those are their activities of daily living, getting out of bed, taking a bath, using the bathroom, doing the things they like, or participating in society as a member, right? So this is where rehabilitation begins. The thing is, writing physio on a piece of paper is never going to be enough because there's a lot more to consider, including environmental factors and personal factors. So all this comes into play when you want to treat a person. What we have created is a culture where people are brainwashed to get pills and go home. And they completely miss on the point of healthcare, which is taking care of themselves as people. Now, rehabilitation is more than just that what. See, what happens is people look at what the condition is and how they can treat it, right? But rehabilitation is all about taking care of the person who has a problem. And specifically, that is, why is there freezing of gait? Not that there is, why is there camptocormia? Not that it's there, just why is it there? Because once you analyze why, you can start figuring out how to treat it. Freezing and gait and camptocormia in different Parkinson's patients will come from different reasons and can be addressed differently. So all this information now modifies the treatment plan that we're going to make. It would not be complete without talking about tablets to some degree, so I'm going to oversimplify them. Tablets for Parkinson's can improve dopa and ACH symptoms. They can also lead to dependence and psychological issues. They cannot fix the non-motor symptoms like pelvic floor dysfunction. The one thing that all these medications do is they make a liminal space. Without the tablets, people would be dying faster and having more complications. When you bring these tablets in, their lifespan is prolonged because they're getting what they're missing, which is wonderful. The thing is, they're still getting a prolonged timeline to the same common end, which all of us face, which is when we expire and move on. Right. But in that time, they watch the activities of daily living deteriorate and their participation in society deteriorate. So where we've lengthened the liminal space that they're going to live in, we have to fill it with something. And what we can fill it with is a self-exercise and rehabilitation program that they can use to enjoy the remaining years that they have gained from the drugs. So people ask, where is rehabilitation most effective? And the answer is, you have to look at neurological burden and morbidity versus the exam. So there's people who have a low burden. They don't have that bad a disease and they're very high functioning. And these people will show you the fastest gains and the best gains that make you feel like you've done something wonderful without having done too much are the best to do studies on because they're going to improve whatever you do. There's people who have a low burden disease, but they don't function well. And there's a lot of reasons for this, but they can, but they won't. Now, there's people who have a high burden of disease, but they still function high. They get up, they do their work, they do whatever they can despite having a bad disease. And then there's high burden, low function. This is towards the very end of the disease process. But your best gains will come from those who don't have much disease and can function well, because they can do a lot if you motivate them properly. But that's not all. There's also complexity factors. And those are things like comorbidities, like diabetes. Do they peripheral neuropathy? Do they have vision issues? Do they have hypertension? Have they had heart attacks? What other else, right? All these things factor into how we're going to rehabilitate them. What's their socioeconomic status? Do they have the money to do this? Is it going to be a problem? Where do they live? What can they use in their area to get themselves better? The next thing, and probably the most important thing that most people overlook, is what is your patient type? You can tell a person exercise, they might do this, and it's not really wrong, but raising your heart rate to 90 and keeping there for 30 minutes, this might be challenging, if not dangerous. He might do this for a few minutes and stop. But this is one type of patient: exuberant, enthusiastic, ill-sustained. There's another type of patient. You tell them to exercise, they're exercising, and they come back and say, Doc, I'm doing everything you said. I do it 8 hours a day and I'm gaining weight and I can't figure out why. Give me some new pills. Very common scenario. There's another type of patient. You tell them right from wrong. You show them that they're doing wrong and you tell them how to correct it. They don't particularly care. They're going to do what they want. And when things go wrong, they're going to blame you for it instead. This happens also. The other kind of a patient is the patient who says they can't do anything until you challenge them. And then you can see just how much they're capable of. And they're often capable of a lot, but they're afraid, they're vulnerable, they don't understand what this disease is or why they can't do what they used to. So how do we approach people with this condition? We don't look at a deficit-based approach, but deficits to guide treatment. And the thing is, a deficit-based approach tries to put people into boxes within which you treat that. But people are different. They don't always fit the deficits. Their deficit might be for a different reason. Meaning there's no one-size-fits-all program. You have to tailor these to the patient. All of this is customized because every patient is different from the other. And the exam will guide you to make the care plan for this person, which will be unique and custom for everybody. Here is neurological burden of disease. For the first 5 years of our life, this little green triangle on the left, we are dependent on our family members to take care of us. We eventually get up and start doing our daily activities on our own, and we can move on and make money, make our own families, at which point we get into that red triangle where we're starting to deteriorate and eventually expire. So with people with Parkinson's, they fit more into this green triangle where without the pills and medications, they might die faster, have more complications, or deteriorate faster. With the pills, we're pushing them more into that red zone where they're going to live longer. This is that liminal space we have to fill. But when you fill it, you have to figure out how to treat a person, and you need a scale to do that. So this is a wonderful scale for doing it. It tells you how many sides of the body are involved and how badly involved it is. And with this, we can make a further treatment plan. Honeyar staging links to modified history of disease, simply in that Honeyar 1 requires a different treatment plan versus 2 versus 5. And that's what we're going to expand on here. So it's not a question of if they need therapy, but when they need therapy. And it's more of this. See, Parkinson's is a medical problem. It's not a therapy issue. So there's no amount of therapy that's going to save this person. At some point, every therapy will fail. And it will fail for one of two reasons. Either because the disease is so bad, nothing more can be done, or there's medical complications which require a physiatrist. Your average neurologist may not know how to pick these things up or wonder what to do with them. So let's look at the goals and rehabilitation components. For a Honeyar 1, we want them to be independent for the activity of daily living and do a job. Same for 2. By 3, we want them independent for their daily activities and maybe doing stuff at home because they're a fall risk, they might get hurt outside. 4, We'd like them to be independent, but at least of moderate assistance for their daily activities and at least be part of the family. And 5, minimal assistance as much as possible, total assistance if needed, but find ways to enjoy the life they have. Now, who does that? If you look at this, 1 through 5 can always be a family member. You always need a family member around. You always need a physiatrist to help guide that plan. PT, physical therapy, really shines between 2, 3, and 4 because these are people who have motor deficits that need to be addressed. Occupational therapy really shines at 3, 4, and 5 because you can really improve that activity of daily living with an occupational therapist. Speech and language pathology typically comes in around 4 and 5, where they have a lot of swallowing problems and speech problems. And neuropsychology, from anywhere from 2 down, because they're slowly getting more and more depressed as they watch their body deteriorate. It's not just about issuing a prescription for therapy, though. We have to track the response to it, and we have to see if they're improving with this. If not, do we escalate? If they are, do we de-escalate? That's what we have to figure out here. The problem is you need reproducible objective measures to do, and there's very few. So you set a goal and see if they meet that goal, and if not, why? That's how we move forward here. So what we're going to do is we're going to link deficit to exam to finding, and then make a plan based on this. Is for Honor 1. Typically, these people have balance and gait problems. That is a deficit. The exam will show you eye movement problems, posture problems, and dynamic gait index or tighten up and go will show you abnormalities. The findings, these people have the abnormal psychotic movements, or even the posture type that they have might be abnormal. And in that, you can address the tight and stretched muscles. They also have resting tremors, postural tremors, action tremors. So testing that can help you understand what you're looking at. And from there, mirror therapy or taping should be done. They might have impaired upper body ADLs. So a Solomon's index can be both therapeutic and help you quantify the change and response to treatment. Honor 2 has a lot of the same features as 1, but they might have anxiety and depression also. Honor 3 brings in a whole new set of problems like freezing of gait or failure to initiate, camptochronia, and postural issues. So the exam will be looking at eye movements, posture, tighten up and go, and dyskinesias. You can always plan with audiovisual stimulation to bypass these freezing and gait, and you can address the tight and stretched muscles. They'll also have bowel, bladder, and toilet problems, so you can do a pelvic floor exam and pelvic floor rehab. Honor 4 and 5 typically look the same, just one is worse than the other, but they have sitting balance impairments, transfers to stand, bowel and bladder issues, and the treatments are, as you can see here. So the question is, if you're a doctor and you're going to send a patient to a therapist, what should you tell your therapist? And the answer is, therapy is wonderful. They really do a good job. They're good people. They care. There's limits to what they're going to accomplish with therapy. If you need a consistent product, you have to look in the mirror. What I mean is, you can send a person to a therapist, but you may not get the same therapist every time. They might live in different places. They'll need maintenance care. If you need a consistent product, you look at yourself, you understand what the disease is and how you want to manage it, then you write the prescription. And if you don't know this, there's no quality control in the process. The last thing is, don't make your patients dependent on all these things. Give them freedom to improve on their own. So when do you need home therapy? When a person has contractures, when they can walk but won't, when they can do their daily activities but won't, or they're lazy. Now, the last two, previous two, they look like laziness, but there's many reasons why a person can walk but won't. It could be fear, it could be balance issues, there's many things. So if you don't sort it out, it won't be enough to just say, get home therapy. Do these people need durable medical equipment? Upper extremity orthotics are of minimal value. They tend to promote a kyphotic posture, since patients already have, that can make retropulsion worse. You can use 3D printed finger splints for dystonic finger posturing. Lower extremity orthotics usually are not needed, and walking aids can get them walking but create posture problems or dependency. There are a lot of musculoskeletal issues that benefit from interventions. If they have myofascial pain syndromes, prolotherapy can help. If they have non-motor symptoms, neural therapy can help. There's very few practitioners of this in India, myself being probably the first. The question is, do we get better by doing a DBS? Eventually, these guys get so bad they might be qualifying for DBS or apomorphine pumps. And the DBS it fixes the excessive positive symptoms, but it leaves the negative symptoms glaringly obvious. So the non-motor problems still persist, and now one complaint becomes a whole lot of complaints about things that haven't gone, and so much money spent. Thank you.